Well, welcome to the Catholic Health Association's briefing on community benefit and tax exemption. I'm Julie Trocchio from the CHA staff. Well, community benefit is very important to us at the Catholic Health Association. Starting in the 1700s, religious sisters from Europe came to our country. They looked around and saw what needed to be done, often visiting and caring for the sick and the poor. You could say they were doing the first community health needs assessments. One of those sisters, Mother Joseph, who brought healthcare to the American Northwest. Now, if she looks familiar, you may have seen her in Statuary Hall representing Washington State. We believe she's been there longer than any current member of Congress. Then in the 1980s, when Congress first looked at not-for-profit hospitals and whether they deserve tax exemption, CHA developed a list of community benefits. Activities we believe distinguish not-for-profit hospitals based on IRS rulings and our members' experience. We developed an accounting system to go with the categories. The IRS Form 990 Schedule H was based in part on those categories and our accounting system. Now, while mission is the primary reason our members and other not-for-profit hospitals provide community benefit, they are also guided by very specific public policies, including the IRS tax code and rules. For over 30 years, CHA has developed educational materials on how to provide community benefit, including this guide. Let me show you our guide, and other materials for providing community benefit. And this is the process that our guide describes. Well, today we have 3 speakers to talk to you about community benefit. First, you're going to hear from Stephen Clark, Executive Director of Exempt Organizations of Tax Services of Ernst & Young. He's going to cover the policy basics of community benefit. Stephen previously served at the Internal Revenue Service, where he led the revision of the Form 990. Next, you're going to hear from 2 community benefit leaders, Coletta Barrett, Vice President of Mission at Our Lady of the Lake. She's going to tell you about community benefit needs assessment in Baton Rouge, Louisiana. Then Marcus Pesquera, Vice President of Health Equity, Diversity, and Inclusion from Christus Health, will discuss how his organizations provide community benefit. Now, if you have any questions for any of our speakers, please put them in the Q&A box, and we'll get to them after the presentations. Stephen, we're looking forward to hearing from you.
Thank you, Julie. Appreciate the introduction, and thank you all for tuning in. Today, I'll cover just a couple of areas: basics of community benefit. What is it? What is reported on Form 990, Schedule H to the IRS each year? And then I'll talk briefly about who regulates community benefit. Let's kick it off with an overview, an executive summary, which should be on the next slide. And one more. Thank you. So first off, for a hospital to qualify as tax exempt from federal income tax, it needs to meet what's called the Community Benefit Standard. And that standard was established by the IRS in 1969 through a revenue ruling, 69-545, which set forth a facts and circumstances test that hospitals have to meet to show that they're operated to promote the health of the community as a whole. Subsequent to that, many years later, when the Affordable Care Act was passed, it created a new Section 501R of the code, and that includes various requirements dealing with financial assistance policy, limitations on charges, billing and collections restrictions, and a requirement that hospitals complete a community health needs assessment at least once every 3 years. So hospitals must annually demonstrate compliance with both of those standards, the Community Benefit Standard and 501R, to continue enjoying tax-exempt status. The IRS reviews the Schedule H filed on Form 990 each year by hospitals. And by the way, for those of you who don't know, Form 990 is the annual information return that all tax-exempt organizations, or at least most of them, have to file each year, showing that they continue to be operated for charitable or other tax-exempt purposes. And the IRS reviews those forms and from time to time examines organizations to ensure that they're meeting their charitable standards under 501c3. On that form, there's a special schedule, Schedule H, that hospitals have to complete to report multiple categories of community benefit. Now, when some people think of community benefit, they think of financial assistance, free care or discounted care to indigent persons. That is one type of community benefit, but that's not exclusively what hospitals report. There's multiple other categories, and I'll detail some of those in the coming slides. That Form 990 document is publicly available. The IRS posts the Forms 990 from the three most recent years on its website. And there's multiple other organizations privately that post 990s as well. Community benefit is regulated by several groups: Congress, IRS, and state regulators. Most state regulators impose some kind of community benefit requirements that are similar to, but supplement, the IRS's community benefit standard. All right, let's move on to the next slide. What is community benefit? I'll go through the various categories of community benefit that hospitals report on Schedule H, starting with the next slide. Now, this is a overview of the community benefit, the types of community benefit that the IRS has defined as being favorable types that help an organization to qualify for and maintain its tax exemption. There's not a specific quantitative standard. For instance, there's no minimum threshold of financial assistance that a hospital has to provide. In fact, under the community benefit standard, a hospital doesn't have to provide any free care or discounted care. It only has to show that on the whole, it's organized and operated to promote the health of its community. It can do so by showing it offers free care or discounted care. But there's a number of other positive factors as well under Revenue Ruling 69545, including having a community board that's representative of members of the community who represent community interests and don't have any financial interest in the hospital, such as being employees or otherwise paid by the hospital. If the board is primarily community members who are disinterested, that's a positive factor. Having a medical staff open to the community as a whole, also a positive factor, as is an emergency room open to everyone in the community that provides care to whoever in the community comes into the emergency room. Another positive factor is that the hospital provides non-emergency care to everyone who's able to pay for the services. Notice who's able to pay, no requirement that the hospital provide that care for free. Another positive factor is using surplus funds to further charitable purposes, such as improving patient care. And finally, if a hospital conducts medical training, education, and/or research, that is also a positive factor. Other factors that the IRS takes into account in determining whether a hospital meets the community benefit standard, and these are factors that have been put into play through subsequent IRS rulings. One is serving those who are Medicare and or Medicaid patients. Another is providing medical care for those who can't afford it. And finally, promoting health and meeting community health needs in a charitable manner. You can see there's 8 types of community benefit reportable on Schedule H. And again, community benefit is not synonymous with charity care. It's a larger concept of which charity care is just one of 8 different categories. Charity care is also called financial assistance, and to the extent a hospital incurs cost to provide it and suffers a net loss from providing charity care, it can report both in gross and at net the financial assistance it provides. And that's true with all these categories. In Schedule H, the hospital provides both the gross expense of providing these types of community benefit, and then the net expense after offsetting revenue is subtracted. You can see all 3 of those categories: gross community benefit, offsetting revenue, and net community benefit on Schedule H. Second category is Medicaid. To the extent a hospital incurs net loss from providing Medicaid care. It can report that on Schedule H. Other means-tested government programs like state programs, equivalents to Medicaid, Medicare can be reported. Community health improvement services, which are services of a non-clinical variety intended to meet community health needs, are reportable. Subsidized health services of a clinical variety that the hospital operates at a loss to meet an identified community need are reportable. Research, not all research, but research that's generalizable, meaning conducted for public benefit, the results of which are made available to the public. It's not sponsored by a for-profit group like a pharmaceutical company, but rather sponsored by tax-exempt or government entities or self-funded is reportable. Health professions education that's available to the community as a whole, like education programs that are needed for physicians or other medical professionals to qualify for licensure or to maintain licensure, that's reportable. And finally, cash and in-kind contributions to other third parties in the community, like other hospitals or clinics or community health groups, is reportable if it's restricted for one of the types of community benefit listed in 1 through 7 here. And notice that asterisk at the bottom. Community benefit reports by third parties, like you might have seen reports by the New York Times or Wall Street Journal in the past year, or Loan Institute or other associations. Interestingly, most of these press outlets or research groups don't report on all 8 types of community benefit, but they pick and choose categories that they think are community benefit or charitable. Oftentimes you'll see financial assistance and charity care. Sometimes you'll see Medicaid included. Sometimes community health improvement services, but oftentimes only a couple or a few of those categories are highlighted by the press, which usually neglects the IRS community benefit standard. It doesn't describe what actually counts as community benefit for tax purposes, but rather what these outlets think are favorable to the community. Let's move on to the next category. This describes financial assistance, Medicaid, other means-tested government programs that the hospital provides at a discount or for free to individuals who qualify for assistance under its financial assistance policy because they can't afford to pay for some or all of their charges for medical services. They oftentimes are under a certain percentage of the federal poverty guidelines in their income, like under 400%, 300%, 200%, et cetera. Also, Medicaid and other means-tested programs and the expenses from those programs are reportable. Let's move on to the next category in the next slide. Community health improvement services are non-clinical services carried out to meet an identified community health need that either the organization has identified, for instance, in its community health needs assessment, or some other community group, like a government health agency, has identified. And the organization offers these without receiving inpatient or outpatient revenue, sometimes for a nominal cost, such as community health screenings, support groups, community health education, et cetera. Let's move on to the next category, which is subsidized health services. These are clinical services that the hospital also provides to meet an identified community need that may be identified by its community health needs assessment or by another community agency like a government health organization. And that if the organization didn't offer the service, that service would be unavailable or not adequately available in the community. And examples, fairly common examples of these services are burn units, trauma services, behavioral health like mental health, substance abuse programs, more recently, COVID-19 dedicated clinics or units. So you won't find, interestingly, subsidized health services specifically called out in RevProc 69549 in the Community Benefit Standard. But the IRS's reasoning is that these services are provided to meet community needs, and the hospital loses money for doing so. Therefore, it's done in a charitable manner. That doesn't mean that for-profit counterparts would never offer these services, but I think you'll find that for the most part, you'll much more commonly find subsidized health services offered by tax-exempt hospitals. Moving on to the next category, research. To the extent that the research is either self-funded or sponsored by a government organization or another tax-exempt organization, and to the extent the results of that research are made available to the public, such as through medical journals and other public forums, that research and the cost of the research are reportable as community benefit. And again, there's a difference between net cost and gross cost. Oftentimes, the net cost of research reported on Schedule H is much less than the gross cost because of research grants that the organization has to report as offsetting revenue. Let's move on to the next category of community benefit, health professions education. This, like research, is spelled out as a community benefit category in the 69-545 Community Benefit Standard. And to the extent that the education program offered by the hospital results in a degree or certificate or other training that's either necessary to be licensed to practice as a health professional or to continue to maintain that license, that's reportable as community benefits so long as all physicians or health professionals in the community are welcome to participate in the program. It's not just available to the organization's employees. Let's move on to the next category, and this is the last category of community benefit, contributions for community benefit to other community groups, like other tax-exempt hospitals or clinics, or say free clinics or other health groups in the community. It could be government as well. Those grants must be restricted in writing to one or more of the activities constituting community benefit, which I've described in the prior slides. All right, moving on from the categories of community benefit reported on Schedule H to how community benefit is regulated. There are three main regulators. First of all, Congress, which instituted Section 501c3 years ago, and that's a general charitable category for tax exemption, covering charities as a whole. No specific standard there for tax-exempt hospitals. However, with the passage of the Affordable Care Act, Congress did impose very specific requirements upon tax-exempt hospitals, in addition to the community benefit standard. Required hospitals to adopt a financial assistance policy and to promote that policy to all patients, and include in the policy specific procedures for qualifying for financial assistance, the specific types of assistance available, and information on how that policy is enforced, and various related information. It's also required, the hospital is, to conduct a community health needs assessment at least once every 3 years to identify priority needs in the community and how it plans to meet those needs. And there's also limitations on how much a hospital can charge and restrictions on its collections activities. The Internal Revenue Service enforces both of those standards, 501c3 and the related community benefit standard, and 501r. It does so primarily by looking at hospitals' websites and its Form 990 Schedule H. State regulators, and there are many of those, most states impose some sort of regulation on hospitals, tax-exempt hospitals, and some kind of community benefit requirements as well, whether reporting and or provision of community benefit. Let's move on to the last slide. IRS scrutiny of community benefit. Actually, one quick note before I get into IRS scrutiny of community benefit, just two examples recently of Congress's regulation of hospitals. You may have seen a letter that was sent to the IRS by Senators Grassley, Warren, Warwick, and Cassidy on August 7th, 2023, that expressed concerns that hospitals aren't meeting their obligation to provide free care or discounted care. Now, again, there's actually no obligation for hospitals to provide free or discounted care to qualify for exemption. That's one way they can meet the community benefit standard. There's multiple ways. But these senators were concerned that hospitals aren't providing enough free care or discounted care, and asked the IRS to respond to about 8 different questions, also asked TIGTA to respond to about 10 different questions on the extent to which and effectiveness with which the IRS is enforcing these standards. Also, you may have seen Representative Victoria Spartz on September 29th introduced the Nonprofit Hospital Tax Exemption Transparency Act, in which she proposes a new community benefit standard that would replace the existing community benefit standard. This would have only 3 factors. 1, community board, representative of members or of interest in the community. 2, serving Medicare and Medicaid patients. And 3, hospitals would have to meet an expenditure threshold equal to 100% of the value of its tax exemption through 3 types of community benefit. 1, free and discounted care. 2, education and research to improve patient care. And 3, improvement to facilities and equipment. Notice that Representative Spartz uses 3 of the 8 community benefit categories, and Schedule H just ignores the others. Okay, finally, let's talk about, very briefly, IRS regulation. The Affordable Care Act requires the IRS to review at least once every 3 years the community benefit of every tax-exempt hospital. So effectively, each year, it's reviewing the websites and the Schedule H's of approximately 1,000 exempt hospitals. It doesn't let those hospitals know it's looking at them unless it chooses one for an exam or a compliance check. And the IRS has examined hundreds of tax-exempt hospitals over the last 6 or 7 years, and has imposed over 100 penalties for failure to conduct or adequately conduct a community health needs assessment. Those penalties are $50,000 a piece. So the IRS has been active in enforcement of 501R standards. And with that, I'm going to turn it back over to Lucas. And if you have any questions, feel free to put them in the Q&A, and I'm happy to answer them at the end of the presentation. Julie, you're on mute.
Thank you so much, Stephen. We really appreciated the detail that you were able to provide to us. Thank you so much. But now we're going to turn to how hospitals provide community benefit. Now, here are the IRS requirements for conducting a community health needs assessment, or CHNA. Then on the next slide, you'll see these are the requirements for developing implementation strategies. So what the IRS tells us is, first, we assess community health needs, we set priorities, then we plan to meet those needs, and in the next assessment, we have to report on the impact of those activities. Well, given those rules and regulations, let's find out how it actually happens. Colette, welcome. Tell us what it looks like in Baton Rouge.
Thank you very much, Julie. Colette Barrett with Our Lady of the Lake Health in Baton Rouge, Louisiana. We are a part of Healthy BR. If you click through, it'll come up with the mission of Healthy BR is. We are a not-for-profit established in the community. We gathered in 2008 by the mayor's invitation to address the health of the community. And then in 2010, we created a not-for-profit. Next slide. You can see who the members on this board of directors are. And in 2010, when the Affordable Care Act was passed, we looked at the requirements, and as a board said, it makes sense for us to do this collectively because all 5 of the major hospitals in Baton Rouge are on the board and a part of Healthy BR. So if you go to the next slide, you know, why did we even exist? It was because as we look at the community's health, in our state, our Office of Public Health is organized in regions. We are in Region 2. And our public health does only those services that public health can provide: disease monitoring, management, vital statistics, etc. When it comes to health prevention and promotion, they have to turn to the public-private sector to actually implement those things. So we do it in collaboration and planning with our public health department. But the local health, the department that would impact everyday life, we as a group say we step into that space and we work to fill the gaps in our community. And so next slide, with this public-private partnership that we have with the Mayor's Healthy City Initiative, we made the decision that we would collaborate on the community health needs assessment. Now, in 2012, when the first one was done, it truly was a collaborative CHNA where we did the research, the study, the data, the statistics, and came up with the prioritized areas. But each one of the hospitals had to do their own because there wasn't guidance from the IRS on doing a joint community health needs assessment. If you fast forward 3 years to 2015, not the slide, if you fast forward to 2015, we were able to have a joint community health needs assessment as created by the regulations that were coming down from the IRS. So all 5 of these hospitals in our community, their boards signed off on the public that we would serve and created this joint community health needs assessment and the implementation plan that follows, which is the key differentiation for us in the Baton Rouge community than other joint community health needs assessments. Our individual hospitals do not go off and create their own individual implementation plans. We may have individual implementation strategies, but we all report into the same implementation plan. Therefore, we can focus our efforts on those key priorities and move the needle on some of these community strategies and the population health change quicker. Next slide, please. So we do that, and we do this with what we call a collective impact model. And we believe this is what differentiates our approach, is that we do have a shared vision and a common understanding of the problem, and that is driven by the community health needs assessment. When the shared measurements, we have the data that we all agree, and we have subject matter experts from across the community that come together to help us define and prioritize what those challenges and those changes are. And then we look at how are we all working together? Where are the gaps? How do we fill those gaps? And what do we do together to move our community forward? Because Healthy BR serves as the communication platform and the mayor's office as the convener, we have this backbone organization support for bringing other not-for-profits to the table to help fund this work as well. So if you go to the next slide, I think it was really important that Julie talked about the structure and process of following a community health needs assessment. And this is how we go about doing that work. We really have MedBR that comes together to look at the improvements that have been made to manage the community health implementation plan. We run the data. We work with our partners to analyze the data. We come up with what are those prioritized efforts. We disseminate the findings widely across the community, and then we work collectively over the next few years to move the needle. So if you look at the next slide, I just wanted to highlight for you, if you go to healthybr.com, which is the website for our work in Healthy BR, you will find the community health needs assessments from 2012 up to 2021. I think it's really important that you see that this is a collective work. We take this work in Baton Rouge very seriously, and all of our hospitals commit to this work collectively. So in our 2021 CHNA, these were the top 10 community health needs that were prioritized that the data drove us to with our subject matter experts. If you go to the next slide, it's not enough to get the subject matter experts. We need to listen to the voice of our community. And so we used in Baton Rouge the public library system, because we are blessed that we have a very robust public library system. You can see the red dots all across the community where we have libraries. And I want you to highlight that those yellow areas are communities that have a high needs index of 4.2. So we have libraries in all of those communities of need. So we're listening to the voice of our community that is sometimes more disaffected. And so when we get the input, these are where our priority led us in 2021, a focus on mental and behavioral health, addressing health equity and racial disparities that were so much highlighted in our COVID work. The healthy living, lifestyle management, maternal and infant health. Unfortunately, we have very high rates of maternal and infant deaths in Louisiana and in our Baton Rouge area. And yes, today, still in our community, sexually transmitted infections, HIV, AIDS, and hepatitis or a community health need for our organizations. Where people live make a significant difference, and this is how we highlight and make sure that we're listening to the voices of our community. And we have significant needs that exist in the community. We have what we call a tale of two cities. We have the East Bank and the West Bank of Ascension Parish, where Donaldsonville is one of our most impoverished areas. And then, above Florida Boulevard and below Florida Boulevard. So we have these areas that take specific focused areas to improve community health. One of the things that's really, really hard to turn away from or turn a blind eye is I can go down Park Boulevard if I leave Louisiana State University and go down Park Boulevard out of the campus. And if I turn right into the Garden District, or if I turn left into the Bottoms, it's a 17.1 year difference in life expectancy if I turn right or left off of that street. So we take that seriously and work together as a community to address those needs. Next slide, please. This is where, next slide, please. This just tells you how that community needs index was done. So social determinants of health are really important. That is another way that we identify needs. And so all of that comes together so that we can then populate our implementation plans. If you go to the next slide, this is where our 5 priority focus areas then are populated, and we share our data. We share our information, and we look at community level data to tell us, are we really making a difference? I just want to highlight something for you as an example. While HIV and STI still remain on our community health needs assessment, we have done significant work through the years. Most of our hospitals, not all of our hospitals now participate in opt-out testing for HIV. In our women's hospital, they do it as a part of prenatal care. At Our Lady of the Lake, their emergency rooms all have opt-out HIV testing. Ochsner expanded theirs, and they began doing opt-out testing 2 years ago. And this year, Baton Rouge General Medical Center joins us in doing the opt-out testing for the emergency room. That helps us expand community testing in what may be considered high risk or vulnerable populations. And to give you a success story, in 2012, we identified overutilization of the emergency room as one of our key drivers to drive down costs that would free up resources to address public health. By 2015, we had driven down avoidable hospital days through emergency room case management programs and extending after office hours, and promoting payment for after hour clinic visits, and expansion of urgent care to address those issues. And so overutilization of the emergency room came off of our prioritized list in future CHNAs. So by focusing on areas of improvement and collectively working in our own ways, we are able to address significant population health issues in Baton Rouge. And if you have any specific questions or comments, please put those in the chat and we'll answer them at the end of our time together. Thank you.
Thank you. Thank you so much, Colette. And I always look forward to hearing the updates over the last 15 years of your community health needs assessment and your implementation strategies. Thank you so much. And now we're going to hear from Marcus Pesquera from Christus. Marcus, tell us about how Christus provides community benefit.
Absolutely. Thank you, Julie, and thank you, Coletta, and good afternoon. Thank you for the opportunity to share some of the work as it relates to community benefit. And I would like to share strategic ways in which we integrate our expertise as healthcare providers to improve the health and well-being of all of our communities, particularly those that are most vulnerable and underserved. Christus is in Texas, but also in Louisiana and New Mexico. And I'll go briefly a little bit about how we're organized ourselves. No, go back to the previous one. All right, so these are the 3 areas, if you will, that are focused under the department that is in charge of ensuring community benefit is done. It's health equity, it's diversity and inclusion, and community health, because we strongly believe that a diverse workforce that represents the communities we serve is able to help our system of care best understand the realities of our patients and our community, so we can create solutions that are relevant to the local challenges that our communities face. So we want to promote a culture of D&I, ensure healthcare that is equitable for all, and then impact community benefit investments, make sure we're doing the best with that. So next slide. All right, so this is a little bit of the process, and I think Coletta went through it, but a couple things to highlight here is how we have the software tool, the diverse community advisory councils at each one of the different hospitals, but we focus a lot for this 2023 community health needs assessment and implementation plan on community engagement and data collection. So together with the hospital and the community partners, we went ahead and designed the community survey itself, because we want to make sure we got to the folks that we want to serve, that are experiencing the challenges, the health challenges. And we work with our community partners to distribute to community members, to community partners, to the clients, and even our associates, because our workforce is part of the community itself. So during this process, we also align our demographic data collection clinically with our community to make sure there's a robust data set that can be used to make informed decisions. So that means, in addition to the race, ethnicity, age, language, disability status, gender, or payer mix, we're also capturing the zip codes to tailor cultural competency to the programs that we deliver. Emphasizing that, emphasizing what is collected is not really why we do what we do, is to create community programs that understand the inequities of our patients and the inequities that our communities are experiencing. So that was one area of focus. The other area of focus here is communities of focus, which we focus very hard on that this year. They're also known as target populations, or the zip codes of focus, which we applied to many of our community health strategies. So with numerous studies and statistics demonstrating that people experience different opportunities to live a long and healthy life, depending on where they live, it was important for us to dive deeper into the zip codes data that we collected. And this generally revealed that social and economic disparities across our service areas definitely exist. Here's just a quick example of our community engaged data collection. This is in our Corpus Christi region in Texas, and how we, in that region alone, we got about close to 500 surveys that were filled by our communities. And interestingly enough, they were done in at least 7 different languages: English, Spanish, Portuguese, Haitian, Creole, Chinese, Vietnamese, Arabic. Those are the top languages according to the census in that area. We distribute this surveys, trying to gather data from our communities through paper, through QR codes, through survey links, to make sure that we really reach hard to reach communities and populations, because we do want to hear from them. So it's good to partner with our communities in order to, because they're their clientele. We've got homeless shelters or food banks or other nonprofit that service our most vulnerable, and we want to get in front of them. And we distribute them, just as Coletta said, through different emails, networks, waiting rooms, public libraries, large apartment buildings, etc. So, and then in addition to that, this tool that you see here, we can transpose later on then some federal data, county data, state data, city data, and then be able to create these communities of focus. Next. All right, so there's 5 criteria that we use to pick those communities that we want to focus on. So we started with our primary service area zip codes, which for Christos Health, we define it as, where 80% of our patient discharges come from, right? That's the primary service area. Then we also, of the primary service area codes, we pulled the general census population data through our tool, and then included patient visits to see who's coming in, what are the conditions that are coming in, et cetera. But we also look at this social vulnerability index by zip code. Social vulnerability index is the resiliency measures of communities when confronted with disasters. We also put them through the Economic Hardship Index, which was developed by the American Health Rankings, and then also through the Area Deprivation Index, which was developed by HRSA, which measures socioeconomic conditions of a community. We found out that if a community scores high on one, it's probably going to score high on the other ones. But in addition to that, we included life expectancy just to reconfirm our findings before we decide and hone in exactly on what zip codes do we want to put the majority of our investments for community benefit so they can have the largest impact in the health of our community. So, all right, next. So after identifying, our communities of focus, we applied this concept, right, of 3 strategies. One is the mission anchor mission, then also the community benefit programs, but also investments. And on the anchor mission is we look at local hiring by vulnerable zip codes, and I'll have an example of that in a minute. Under community health and wellness, we look at cultural competency and the health equity lens. And then investments is, in addition to cash contributions to nonprofits to help us address the issues, is time, treasure, and talent, is all of those. So after pulling all this information, system, and that's next slide, please. And that's heart disease and food insecurity. And we also adopted a public health framework to help us understand the issues and how to shape our programs and measure the appropriate outcomes. And next slide. That framework is called the Community-Informed Decision-Making or Results-Based Accountability Framework, which helps us to create strategies based on what the data is showing us that answers the questions: if we don't do anything about this issue, what will happen? And if do we have the resource to do what we need to do for the issue? And then how do we measure appropriate impact? So after going through that exercise, we decided on 2 programs that I want to quickly share with you. Obviously, there's a whole host of other programs. One of them is the food prescription program with the purpose of improving the health of communities. We focus primarily on patients that were food insecure, diabetic, and hypertensive. Just to start the program going and see how it went. It's been quite a success. We have medical providers across the community to refer eligible community members, patients, and their families to the food bank. We ensure that they're enrolled in the program and once they're enrolled, they receive monthly food boxes. We also enroll them for a year, but then ask them to come up for a follow-up for a medical visit once they're enrolled. And the reason is we want to make sure we can analyze what's the impact of this program. Are we having an impact on their blood pressures or their hemoglobin A1C or their BMI? That's definitely important. Then that's one of the programs for food insecurity. The next program, which is the next slide, is the Community Health Workers Program. I love this program. It's in partnership with AmeriCorps. We have 2 areas that we're focusing on. One is building internal capacity. So to the left, you see, we're asking this AmeriCorps Community Health program coordinators to help us maintain a community resource data that will benefit all of the different organizations that we partner with in order to really have a great assessment as to what are the great resources that we have in the local zip codes. Measure our impact, improve community relations and building and the local hiring. And interestingly enough, it's have been very beneficial because we hire individuals from vulnerable communities, which then help the economic viability of a zip code as well, which is part of the things that we want to have an impact. And then from the public health, community health worker side, they conduct social determinants of health assessments to see what are the needs, the social needs, build relationships with the patients, with the healthcare providers and the community, provide navigation services. And the interesting thing about this program is that these community health workers are located in our partner organizations, not necessarily our hospitals. So that's how the partnership is. They service some of our patients. Sure, they're food insecure. We know who to call, but we have this individual there that is helping the community at large as well. So, they're housed in the community partners, which is they can deal with the public, with the community, with their peers. And that's how we're able to integrate all of our programs throughout the community. So that was a brief summary of a couple of our programs, and thank you.
Thank you so much, Marcus. We really appreciate that. And it's so interesting the way you honed in on populations of special needs and your use of community health workers. Well, I also want to thank Stephen and Colette for all that they provided, the information that they provided. So thank you very much. Now, if you have any questions, you can either put them in the Q&A box or be sure to reach out to Lucas Swanepoel, who is the legislative staff person at CHA, who is our lead on community benefit and tax exemption. And also, here are some resources that you might be interested in reviewing, and you can see them in the chat box how you can get to them. Please let us know if you have any questions or you want additional information. Reach out to Lucas, reach out to me, or we could put you in touch with the people from Baton Rouge or from Christus. I want to thank you all for joining us, and I wish you a very, very pleasant afternoon.